All right. So for folks who might not have been to the BHA technology office hours before, this is a meeting hosted by the BHA Health Information Technology team for behavioral health providers, specifically data and admin team members, although we welcome any roles. And throughout these meetings, we provide consistent updates on changes and improvements to BHA managed technology systems. We surface and discuss technology related questions with the BHA technology team. We give it an opportunity for you all to provide feedback and expertise to our ongoing technology efforts. And we use it as a moment so that you all can understand what opportunities exist to engage further with the BHA technology team. I dropped some links into the chat, and one of those links is a link to our provider's BHA webpage where you can look at all of the past recordings and slides from past technology office hours from 2023. A couple of plugs. We do have a hot topic survey that we look at every month. We've only gotten 2 responses since we've launched the hot topic survey. So we would really encourage you to try to use that survey, and I link to that in the chat to provide different topics that you'd like us to talk about next month. By filling out that survey, we just make sure that we have the right people on and we can prepare slides around those topics. So if you ever think of anything and think, hey, would love to talk about this at office hours next month, the survey is always on the provider website, and it's also in the chat today in case you want to bookmark it. A couple of other plugs. So we also have our BHA provider support email. If you have any issues, you can use the subject line office hours or any subject line, and we'll get in contact with you and help you out. And I think that is the most of the housekeeping that we have right now. Again, those links are all in the chat, so everybody should be able to access them. So as we emailed earlier this month, we have a couple of quick updates to go through. I'm going to hand it over to my colleagues, Jackie, Sharon, and Dan to go over some training schedules for the next couple of months. And I put a lot of those links in the chat already. And then I'll take over from them and talk a bit about updates to the referrals platform and CCAR DACOD's modernization. And then at the end, we'll have probably around a half an hour for folks to come off mute or use the chat function for a general Q&A. And we'll answer what we can. And if we can't answer it, we will bookmark it and get back to you and the whole group with an answer. Any questions before we jump into the meat of the meeting today? Awesome. Well, we want this to be super interactive, so please don't feel free to raise your hand, ask questions in the chat, however you feel throughout the presentation today. But first up, I'm going to hand it over to Jackie and Sharon and Dan to talk about a couple of training opportunities we have coming up in the next couple of months.
Hello, everybody. My name is Jackie. For me who don't know me or who've been around a while, I am the I don't even know what I do anymore. The criminal justice data and DUI specialist, and basically support for our 2 legacy data systems that are currently being updated right now. But in the meantime, we got to keep those going. I have now put on the agenda for some CCAR training, basic CCAR training that will take place. I'm trying to do monthly. First start off with CCAR, and then I'm going to add a little bit more, only that we are getting tons of new users accessing CCAR lately. So, and Mike could probably attest to that. We have just been bombarded giving people access. The one thing we want to enforce on our data system is confidentiality and PII, and basically some of the information that what happens is our data systems have been set up that if there's no activity in a 90-day period, they're going to be locked out. And this is the security feature, which helps to keep the client's PII out of wherever. But if they will lock them out, and then they will have to fill out a form. But that's one of the main topics we're going to talk about because it comes up all the time. CCAR, for those who don't know, is the Colorado Client Assessment Record. basically for mental health designated providers. The DRS training, which I've been doing for many, many years. CCAR is kind of new. I just received my clinical license a couple of months ago. So understanding the assessment part of the CCAR makes it more able for me to kind of give more information during the training. Now with the DRS, basically is for DUI offenders. That's where we're going to track the DUI clients who are either being supervised by probation or monitored, or who are just trying to get their driver's license. So those DUI providers that we license also may provide other types of SUD treatment as well as some mental health treatment. And I go through all of that with them as well. And the dates that I provide right there, you'll see are on TMS when you log in. And just the day of the training, I give specific information just to log in. And we kind of go over everything. We go over granting credit, out-of-state offenders, the interlocked enhanced counseling. What if somebody reoffends? Residential treatment, and it just goes on and on. And I don't want to get into all that because I don't even know how much time I have, but that's just the meat of it right there for DUI. But we're tracking those offenders. I work a lot with the judicial side as well as CDOT on the DUIs in the state of Colorado. The next slide, I believe, is day codes. Day codes is our drug alcohol coordinated data system that we track. And again, that's one of the data systems that they're currently working on to replace. That training is provided monthly as well. And we go through all of the information that is to be recorded in the system. There are some providers, such as the ones that receive grant funds, they go through their own portal, which is an MSO. But for the ones that do not, that submit manually, they will go directly into day codes, and then I go through the training for that. Also in that platform of the treatment management system, I do provide lots of different trainings, such as problem gambling. This is an addiction. So a lot of the treatment providers that I work with on that end are clinical clinicians that either need to earn CEU hours. We'll host that for them, but they can give this back once in a while. They'll have somebody that may come in for some treatment for gambling. And so we put the link up there. And then that particular one for the gambling is basically, it's only, it's a self-paced training for individuals who can complete the training of their choice. But again, it's there's opportunity for them to get scholarships or funding. And again, that's a message towards the treatment providers. So we do a lot of that. In addition, we are working on putting a statewide training for all of our DUI offenders as well as our SUD offenders, hopefully in the spring of 2024. Stay tuned. I will bring up all that information as we get closer. And I don't know if I have any more information on there. Any questions? Because like I said, I've been having a lot of questions about training, and it's just been one of those where we're really short staffed, but it's important for us to get this quality data. So that's when we're putting out this training to get as much as we can in there. So if anybody ever has a question, concern, feel free to email me. Or actually email Troy. Just kidding, Troy. That's all, Abigail.
Yeah, before we move on to the next slide, is there any questions? Does anybody want to come off mute or put any questions in the chat around training? I also wanted to say I'm going to follow up with all of these links and all of these dates in an email that you all will get, so don't feel like you have to write all of this down now. Okie dokie. Well, if you think of anything, just feel free to put it in the chat. Otherwise, I'm going to hand it over real quick to Dan.
Hello, everyone. Dan Vorthams here, your favorite BHC project lead for the BHA. We have Peak Pro training available now from HICPUF. I sent out an information sheet earlier today to the entire email list. As a reminder, we'll be using Peak Pro as a standardized eligibility platform for means tested programs, uninsured, underinsured type programs. I think there's 6 or 7 special studies codes that have that 300% FPL means test. We'll also be using it to create a member ID using the Medicaid terminology because the platform was written for Medicaid, but we don't have members, but we still use that terminology. But a member ID will be used to identify individuals uniquely across the state, all programs, so that we can look at better coordination of benefits once we get the system rolled out. And looking at those benefits, then do some studies in conjunction with Medicaid, which also offers behavioral health services. The information sheet, like I said, was sent out to this email list, but if there's others in your organization that this information might be more pertinent to, please be sure to pass that on within your organization. Having talked to some providers, it could impact what they do at the front desk. The application might be used by intake people. It could be used in billing to verify somebody's Medicaid versus BHA eligibility. So it's got some usage across your entire organization, depending on how your organization is set to function. So please share that information. Right now, we're set to start the first session this month. We had tried to do it this week, but really didn't get enough interest quickly enough. So we're going to start it next week. As the highlights are listed here, it is 3 sessions, about an hour and a half each, scheduled over 3 to 4 weeks, depending upon the availability of the 2 trainers we have in HICPUF right now. The 3 sessions are just the introduction, a full application walkthrough, and then a final topics or Q&A, depending on how the previous 2 sessions went. I think it's totally appropriate for people to attend the training, even if they don't want to get a personal Peak Pro account, so that you can see how the system works and better understand it in relationship to your own operational flow. As soon as I'd like to get 15 to 20 people, but we're going to go next week with what we have. So hopefully we can get a little more participants. Like I said, there's more detail in the information sheet I sent out, but we also need a single point of contact for the organization who requests access at the organizational level. Different forms to fill out, different things to approve. Then the individuals fill out a third-party access request, and all the information on that is in that handout that I sent out earlier today. If you have any questions, again, on Peak Pro, what it's being used for by the BHA, any questions on the information sheet, any questions on the training, please don't hesitate to contact me. Most significantly, you have people who would like to be trained on it so they can start seeing what it looks like and how you can use it in your organization. Please get those people to sign up with me as soon as possible. And that's all I have, Abigail.
Yeah, Dan, we have a couple of questions. So, Dan, if people want to participate and sign up for this, your ask for them is that they email you with all of the folks at their organization that want to participate. Is that correct?
That's correct. In the information sheet, it says to contact both myself and Mike West with that organizational single point of contact, and that might take a little more discussion in your organization as to who that may be. But for individual participants, please email me, and we'll start sending out information on exactly when and where, and maybe do a quick poll with the HICPUF trainers to find the most convenient time for everybody to participate. If you don't get into this session, we will be holding more sessions. I'd like to get through this first 2 pieces of training, the first introduction and the first application walkthrough, before we start scheduling another group to go through the 3 training sessions so that we can adjust training as necessary. And we will have more trainers available starting the first of the year. But I'd like to get as many people into this to get started so we can really judge how it's going to be used in the system. You'll be able to check eligibility. You'll be able to see other benefits the individual may have. Somebody cannot be eligible for Medicaid and for BHA at the same time. So that shouldn't be an issue, but just being able to see who's eligible for the X1 aid code, which is the means tested programs, and the X2, which are the non-means tested programs, be very beneficial for the organization to get in and see how this application works as soon as possible. But yes, long-winded answer, please email me with any participants.
Yeah, thanks, Dan. And Sammy also dropped in that information sheet, and I'll also email that after with those instructions laid out. Another question we have, Dan and Nicole, I see your hand, but I'm just going to quickly go through this. Can you give us short 3-sentence description of what Peak Pro is as a technology?
To sign up for any state or federal benefits that are managed by the state of Colorado, the CBMS system, Colorado Benefits Management System, is the platform for that. It's contracted through HICPUF. Deloitte runs that on behalf of the state. So if somebody applies for Medicaid, if they apply for SNAP, if they apply for CHIP Plus, food, I guess that's SNAP, there's probably 2 or 3 other benefit programs that are available to people in the state of Colorado that are managed through that platform. Peak itself is the application entry point for an individual person in the state of Colorado. Anybody can go to the Colorado Peak website and submit an application for any of these benefits programs. County eligibility workers have a direct path into CBMS itself. Peak Pro is kind of an intermediary application for providers and specialists to use to submit the same applications for the benefits programs. Of interest to BHA providers is clearly, getting people to fill out an application for the BHA services. That application is exactly the same application as is required for Medicaid, so that people are prompted individually on Peak, and the users, BHA providers and county eligibility workers, they're all prompted to suggest the individual apply for both Medicaid and Medicaid and BHA at the same time. That way the person can get, the most appropriate benefits for them. Medicaid eligibility overrides any BHA eligibility, and we like that because of the federal dollars that apply. I think there still need to be a few tweaks to the system yet. For example, MSOs have by contract a requirement that priority populations be served even if they don't meet the 300% FPL. So some of this, what we're doing in the eligibility system, will have some operational mods to it through contract when we get to that point of contract mods with all the providers. I think reading sidetracked by chat here. I think we can learn a lot by the early people going in, getting the training, looking through the system. For those non-means tested programs, if a person comes into an organization and it's clear that they're not going to be eligible for Medicaid, just by talking with them, maybe they were denied already, a person can get a state ID and member ID number with 4 pieces of information in the system: name, address, gender, and date of birth. So that Medicaid ID number is what's going to be used when we get to submitting encounters into the interchange. So there's multiple reasons to use the system, and it's going to be very helpful that people learn how to use the system as soon as possible so we can see what it does for organizational structures. I think that answers your question.
Yeah, thanks, Dan. Nicole, I see your hand.
Yeah, Dan, I just had a quick question for organization side. If there's a few of us that are going to go into training, do you prefer us to stay together as an organization and go into training, or can we go in different sessions?
You can go in different sessions. I just need the single point of contact identified first, because the organization has to request access, then the individuals do. Individuals can get their own account after the second training session. They can start requesting them then. They don't have to right away. But yeah, people can go at separate times, whatever's the most flexibility in scheduling. If we can get some people started sooner, that's good.
Thank you.
And just as an add-on to that, you know, training, just like everything else, training will be ongoing at a certain point as personnel change jobs, you know, move in and out of different companies. So we'll hopefully have an ongoing schedule for training set with HICPUF. Probably won't happen until sometime next year, you know, mid next year probably. But the training should be available on a regular basis once we get rolling here.
All right, and then one more question. So Laura asked in the chat, what are BHA services? And I provided a link to the BHA programs. Dan, is there anything else you'd want to add about that question other than directing folks to that particular page of the website?
Yeah, there's the CBMS is built for Medicaid. The interchange is built for Medicaid. Their benefits plans, and the BHA does not run a benefit plan. So when we put the programs together into the systems through this project, we had to come up with a name. So in the systems, you'll start seeing things like BHA Community Services. That is meant to represent every program the BHA runs that's defined in the Finance and Data Protocol. That's the best place to go find a listing of all the programs. They don't go into great detail on every program. The link that's posted in the chat is the adult programs because it probably is the most comprehensive list, but certainly there are benefits for children, youth, and families as well in the BHA. So it's the Finance and Data Protocol, which is also available publicly on the BHA website under the data section, I believe. So if you really want to go through and look at that and see which programs require the 300% FPL limit, that's the governing document. And again, if you've got questions about any particular program, your organization should be under contract, you know, by the name of the program. And if you're not under contract for that program, you don't offer it. So Finance and Data Protocol is the best place to go for the programs. And again, that BHA Community Services name we had to come up with probably, I think, midnight one night while we're trying to meet a development deadline, came out of BHA Comms. I didn't make it up, but it's a little different and you don't see it explicitly on the website, the BHA website yet. We're working to fix that and define what that really is, but it's meant to be all the programs that are defined in the Finance and Data Protocol.
All right, and I'll say I will find that document for all of y'all. And it looks like Laura, sorry, I don't know the pronunciation, also has another question.
Laura, I'm sorry, I'm not trying to be deliberately obtuse, but this just does not make sense to me. The BHA is an oversight agency, correct? They don't actually directly provide services, and there are multiple entities in the state that are not licensed to be by the BHA to provide behavioral health services, like an FQHC, as an example. So what I don't understand what Peak Pro actually does. Does it establish a benefit outside of the Medicaid benefit to pay for other types of community services? I don't understand.
That's a good question. So I'm going to jump in there and say that there are a couple of different roles for the BHA, and the one that we're talking about here is specifically from a contract or contract monitoring perspective about the dollars that we distribute in community through contractors, less so about facilities or providers that we regulate. So for BHA contracted providers that receive funds to then provide specific behavioral health services, when they provide those services, there's data that needs to be submitted to the BHA. And we are shifting that data reporting process for BHA funded services provided by BHA contracted providers to this process. So people receiving BHA funded services, not BHA regulated services necessarily. I agree with you, Laura, that's very different. Would have their information, they would be enrolled via Peak Pro so that we can see BHA funded services and Medicaid funded services in the same place. And then data submission for BHA funded services and Medicaid funded services would both be submitted in the same place so that we could more efficiently manage those dollars that the BHA administers. Did that help, Laura?
Yes, that does. Thank you, Kristen. Last name, awesome. For the most cogent explanation I've heard of this. It doesn't necessarily, I think when we throw around things like BA providers in the state, we have to remember that this does not apply to everybody. And then, of course, calling it
Absolutely.
peak pro when there's already peak just like doubles down on like the level of confusion, if you ask me.
No, you're
So-
totally right. And I think that we as an organization are working on how we mature those types of talking points, because there's lots of different things that the BHA does. And there's some things that we do via contract and some things that we do via regulation. And we need to be really careful to make sure that we are explaining what we're talking about from that perspective, because lots of different providers or people could be coming to the table for different reasons or having different questions.
And Kristen, we have another question in the chat. How does this apply to programs funded through a capacity-based model? I also want to say before maybe I turn that over for you, this is like the perfect topic that we could talk about having a representative from the program team come and talk with us next month. So I'll just say, it sounds like that might be of an interest, so I can work on that. And then I'll hand it over to Kristen to tackle that one.
Yep. So this, how do I say this? Currently, our process for collecting information related to BHA funded contracted services is to have providers or intermediaries or ASOs, MSOs submit 837 claims information to us. We use that information to then generally, and by we I mean our fiscal and accounting team use that information generally to make sure that there's alignment between what dollars are going out in community via these contracts and what services are being provided. We don't use them as a one-to-one relationship to receive claim information and then pay out fee for service. And we are not planning on doing that in the future. We're going to continue to use this information in the same way as we are or have been in the past, in terms of seeing and receiving that information and doing true up with the 112 payments that contractors have been receiving. Good question, Elizabeth. And I don't know if we have Sharon on the line. What I'm referring to is the current 837 information that is reported in via the CCAR application by BHA contractors. I feel like
Sharon is not here,
Jackie.
Kristen.
Oh, she's not here. So I might have to circle back to you, Elizabeth, on that particular question, just to make sure that I'm not speaking out of turn.
Thanks, I appreciate that, Kristen.
Yeah, and I think we do want ASOs to start submitting encounter information, because we're looking at that continuity of care across various programs. You know, we've talked about it before, Elizabeth. We understand that there's some challenges in provider types, in the types of atypical providers in the ASO networks and stuff. PICPUF is working on some aspects of that, but that is going to be, you know, I think the final challenge in this project is that crisis reporting.
Right, and we can't even do that until Signal's pilot is done, so.
Until we, well, yeah, until
Yeah.
we generate some additional information on what an encounter looks like within the BHA submission. So, yep, you're correct.
Thank you. I like being correct at least one time a day. It doesn't happen every day, though.
Elizabeth, I feel the same way.
Thank you. Daily struggle.
Totally. All right, y'all. These are great questions. Anything else on Peak Pro training or training overall before we go to our next topic? Awesome. All right. Well, I will keep us moving. And again, I'll follow up with all of those links and notes. So no need to worry about that. Okay. So the next topic we have is really exciting. I think folks will be excited about this. So a lot of you probably already know this because you were participants in this research, but from March through July of 2023, the BHA technology team conducted some primary and secondary research on administrative burden, specifically looking at the modernization of CCAR DACODs. We completed that research and we've completed our synthesis. You can see that, that synthesis was still being tackled at the beginning of fall 2023. And we're really excited to begin to share some of the insights and information that we garnered from that research. And hope that within the next week or two, we're going to have an official report and presentation to share with all of you that will comprehensively show what we learned and what our roadmap looks like for the future around this initiative. So at a high level, just a little bit about our methodology. We engaged with 16 provider and service organizations across Colorado. I think we talked with upwards of like 70 providers from those organizations that represent a lot of different roles within those organizations, because we know that it's important to get both the perspective of leadership and also folks that are doing the reporting, whether that's front desk staff, clinicians, or otherwise. And we also did extensive secondary research on policy, legislation, and past modernization efforts, all of which we're kind of building on top of in terms of our knowledge base. So we have a couple of high-level outcomes to share with you all today, with that understanding that we're going to be sharing the full report in a couple of weeks here, just crossing our I's and dotting our T's to make sure that everything's accurate in the report on our end before we go super public. But just as a reminder, our hypothesis for this effort is really that outdated and inefficient state reporting processes create undue administrative burden on behavioral health providers in Colorado, and ultimately that trickles down to a negative experience for people seeking care in Colorado. And our goals for this research was to understand how these reporting requirements influence provider processes and operations, how that carries over into the client experience, and also understand how we might improve our data quality and reduce administrative burden on providers. So I want to sit with this for a minute and share our top 5 insights at the highest level from this research. So I'm going to go through each of these and then pause for reaction at the end. Some of these, might be kind of obvious to you all, but it was an effort for us to go through the process of this research to validate these, and some of them, might feel a little new. So I'll start at the top. So I think this will be not surprising to you all, but the data model for CCAR and DACODs is both clinically and culturally out of date, especially for data elements like gender, race, and ethnicity. We hear that providers are losing out on payment and accurate counts towards contractual requirements due to inflexible data intake into BHA systems and inefficient error resolution processes. We heard that the distinction between CCAR for mental health and DACODs for substance use is perpetuating the siloing of behavioral health care and also creates high levels of data duplication for the rising population of dual diagnosis clients. We heard that basic usability issues, for example, account management, system timeouts, copy and paste functionality within BHA technology systems increases the time and effort and cost required to submit compliant data to the BHA. We heard that today the data generated by CCAR DACODs provides limited benefit to the state's behavioral health ecosystem at large, and that the data is currently truly primarily only in active use for contract and funding requirements, as opposed to larger data analyses that are shared publicly. And then finally, we heard that the CCAR and DACODs requirements are directly and negatively impacting how people experience behavioral health care in Colorado, especially during intake appointments. So I'm going to sit with this for a minute and maybe, ask for a couple reflections from the group. If this sounds right, if you feel like there's something that you would have expected to be on this list that you don't see. Curious for reactions.
I think it hits the nail on the head.
I would agree.
The piece I would add that some of the differences between the CCAR and the DACOD, especially the DACOD, it drives to And it really is this piece of you need to close somebody, where I think clients experience that as I've been fired, and negative experience of care. That's really per the language in the manual.
That's a great point, Cindy. Like the necessity that providers have for that discharge report creates a weird dynamic with an active client.
Certainly not a requirement on the physical healthcare side if we are looking at any kind of parity.
It's a great point, Cindy. Anything else from folks? You can also, this will not be the last time that we talk about these results. So if you need to sit with it, that is also totally appropriate. Pam says, we've never received any feedback, data analysis after decades of submitting this information to the state. So the information is not made useful. That's definitely something we heard, Pam. Okay, so if these are our insights, what does that mean in terms of our recommendations? So again, these are at a super high level, and we're really going to be excited to share a more detailed timeline and roadmap plan for you all to react to and give feedback on. But at the highest level, we've put forward 5 recommendations for immediate action for this report. The first of which is we must update the data model. So we must update the data model for CCAR, DACODs through relevant stakeholdering and federal review processes. And we also must map the data model to culturally competent best practices for front-end presentation. So to break this down a little bit, we know that in past Compass efforts, we've already sort of validated the benefit of combining the CCAR and the DACODs into one data instrument. But this recommendation goes further than that and says, although the federal government moves at a little bit of a slower pace with how they're able to update their data model, what we can do is provide the behavioral health providers of Colorado a best practice clinical and cultural front-facing data model so that what you see and what clients see is reflected of best practices. And then the state is going to take the burden on of mapping those data elements back to federal requirements. Secondly, we need to select a data entry system. So what we'll be doing is performing an analysis of existing internal as well as external technology systems based on a set of recommended design parameters that were created as a part of this research in order to select a new front-facing data entry system. So again, that's talking about the replacement of the CCAR system and the TMS system. We know we need to build this technology system for episodic reporting. So we need to build a reporting environment where we can collect data episodically, aggregating encounters into episodes of care. And I have a diagram that goes into this in just a little bit. But basically this means that we want to ensure that we're building for more longitudinal data as opposed to the admit and discharge reports that Cindy just referenced. And so that really hinges on us doing our due diligence on our data backend so that we're creating more comprehensive whole picture statuses of individuals versus anchoring our data in admit discharge reports. Next, we need to create data analysis dashboards. We need to create standard and customizable data analysis dashboards so providers can track progress towards contractual requirements as well as measures of equity. So we're thinking about, what both do providers need individually, but then also what dashboards we can provide in aggregate in data for across the state. And then finally, we know that and this kind of ties to why we have this type of meeting today. We need to prioritize engagement. So just because we put our stamp on a report doesn't mean that this work is done or even, majorly done. We know we need to create a robust external communication and engagement plan for providers and other stakeholders to foster trust and transparency, and also to hold true to our values of co-design and co-creation, so that we're not, assuming we're making solutions for what you need, but we're actually validating that those solutions will do what we need them to do. I see a couple of chats that I'm gonna look at. TMS is a planned piece of this. Wendy, that is true. And will there be funding and supports in place to implement new systems? Building these systems are costly and timely. Thanks for Leanna for bringing that up. So one of the things that we weren't able to accomplish in this research, but that we know we need to do, is a cost analysis for different provider types based on whatever roadmap we're going to put forward. So we know it's not only costly, the cost changes depending on what your tech resourcing looks like. If we're talking about a rural provider that has problems with even accessing Wi-Fi versus, you know, a large organization with an EHR and API connectivity. So one of the things that we want to do and also share with providers is that cost analysis that will help us to put, you know, numbers and data to exactly what that cost might look like for different provider types. Great questions. Any other questions or reactions on this? All right, I will keep rolling then. So I mentioned the idea of moving towards whole person data. So one of the things that we heard from providers, better error messages when submitting batches. Yep, Joseph, that's definitely something that we've heard and know that the system needs to do better at flagging errors earlier. So you don't have to wait sort of until the end of that batch submission to make all of those errors. Great point. Just really quickly, we have a lot of great graphics that will be included throughout this report. One of which is this one created by my colleague, Chris Pimlott, who is breaking down the idea of what do we mean by episodes of care and moving towards whole person data. So the way that the data is currently collected across these types of reports, back to Cindy's original point, is we have an admission report, we have a discharge report per service, and sometimes we have update reports. But really that only kind of gives us snapshots of that individual versus tying all of the data we have together into a more longitudinal, episodic view of that person's care plan and navigation through the state. So basically what this slide is just describing is that we need to think better about tying our data sources together in order to give providers and the state and many stakeholders a better view of what someone is actually experiencing in terms of their service journey. I also want to share this document, which kind of shows the relationship between reporting requirements and funding. So one of the things that we heard through this report is that the role of this reporting is kind of obfuscated. So it's something that is omnipresent, but we don't really understand why we do it. And we don't do a good job of explaining to our providers as well as to clients, you know, what is this data being used for and who can access it. So one of the things that we'll be working on is better documentation of what these data sources are used for, so that we can better communicate that to you and that you can better communicate that to your clients. So again, my final note on this is like, this is just a taste. We will be following up with a more kind of like robust report and you know, a more detailed implementation roadmap and timeline, as well as like an engagement plan that talks about how we will continue to engage with you all on these items. We just want to thank you for your patience. We know that you know, this is a top priority for the BHA to address and a top priority that providers have. And yeah, more to come. And I also just want to thank everybody who participated in this research. These are all your insights. You know, we're just kind of the filterers and the categorizers, but these solutions all come directly from you. And I hope that you hear your voice in them. All right. Well, I'm going to speed through this because we only have about 10 minutes left. I want to allow for time for Q&A. Thanks for the heart, Elizabeth. I love that. So I think a lot of you all know that we are currently doing work on a referrals platform as well. Some of you might have heard of this project as the bed capacity tracker. But through research, we've sort of validated that a standalone bed capacity tracker really isn't accomplishing what providers need from this platform. So we've kind of like moved towards calling it a more robust referrals platform, though we'll probably have a new name for it when it's really ready to launch. But what's important for you all to know here is that we are both conducting additional research around how referrals are conducted at the state, as well as doing user testing in an in-progress technology platform that will have some of the foundational features and functionalities of this future state platform that we will be launching an MVP version of in the winter of 2024 in January. So my ask here is that I will drop my email in chat. If you are not already included as a test user and want to be, you can email me and I will make sure that you get added to the test user list for November. And we've just been getting really lovely participation and great feedback from folks. So we'd love to have you as a test user in the system so you can help to shape what this looks and feels like in January. So I'm going to stop sharing my screen. That's the scheduled content that we have today. So I'd love to use the last 20 minutes just as a general Q&A. If you have any questions on anything that we talked about today, or if there's another topic that you'd like us to speak on, let us know. So the rest of this time is up to y'all to direct us.
Abigail, I have a question. This is Elizabeth with Carolyn Behavioral Health. In talking about the referrals platform, I know that initially it was meant to be more like a bed tracking system. Could you expand a little bit more about what will be included in that? And is it just for bed track, or just who has open beds? If you could give a little more info, that'd be great.
Yeah, Elizabeth, absolutely. And it's been on my to-do list for a minute to do a better job of having a write-up on the website about this. So hopefully there will be something that I can direct folks to that's more comprehensive than what we have on there right now. But we're thinking about this platform in a couple of phases. So for launch in January, what the platform will include will be inpatient and residential beds. So that is, to Elizabeth's point, the Behavioral Health Task Force in the creation of the BHA and in the creation of a number of recommendations put into legislation that we must have a registry in the state that accurately links the bed availability for inpatient residential treatment. So that is our legislative mandate. And we also know that that is the area of referrals with the greatest need, because oftentimes the people being referred into that level of service treatment have the most complex needs when it comes to referrals. So that's, where we're starting. We're starting with inpatient and residential referrals. And then once we kind of build an understanding of what is working with the platform based on that service, we might have plans to expand out into outpatient care. And then maybe even farther in the future, thinking about care related to social determinants of health. And we're really working in coordination with the Office for eHealth and Innovation, because they're also doing a lot of lovely work around referrals. So we want to make sure that we're not duplicating work on that end, which is kind of why we're phasing it out into those 3 phases. Elizabeth, does that answer your question? Do you want me to go more in depth on any point?
Nope, that was perfect. Thank you.
Great question. Yeah, any other questions around referrals, admin burden? We talked a lot about training schedules earlier. All right. Well, what we typically do if the crowd gets a little quiet is we say that people can take off, and I and the BHA technology team will stay on until 2. But if you need to log off and go take a couple of minutes before your next meeting, feel free to do so. Otherwise, we'll be here and we're answering questions, and we just really appreciate your time, and we'll see you here next month. And remember to fill out the hot topic survey if there's something that you want us to talk about in more depth next month. Thanks, everyone.
Thank you.
Wendy, the recording will be found on the BHA website after about a week after this meeting. And I'll put the link so you have that. There you go, Wendy.
A link doesn't show up.
Oh, it doesn't?
No, it just has your text.
Oh, it's annoying. It might be because you haven't updated Zoom in a minute, but that one should work.
Probably so. Thank you.
Yeah, no worries.